Hi, I'm Dr. Daniel Meyerkort. I'm an orthopaedic surgeon at Perth Orthopaedic and Sports Medicine Centre. Thanks for watching this seminar, which is a comprehensive seminar looking at all the non-surgical and surgical options for treating your knee pain. I've given this seminar live to patients over the last 3 or 4 years many times, and universally patients have given feedback that they find it's a really good first point for patients to understand their knee pain a little better and to understand all of the treatment options, whether it's non-surgical or surgical treatment. Just going to share my screen so that you can see our PowerPoint presentation while I'm talking. Okay, so I have named this talk Contemporary Management of Knee Arthritis, Diet and Exercise, Why Bother? So as an overview, we're going to look at knee arthritis, what knee arthritis is, and when you should consider knee replacement. We're going to look at weight loss for knee arthritis, physiotherapy for arthritis, injections. We're going to look at alternative surgery to knee replacement, and we're going to look at robotic knee replacement. If you look at where or how orthopedic surgeons were practicing 10 or 20 years ago, if you had knee pain, you essentially had arthroscopies, you had cleanup surgery, and when the cleanup surgery stopped working, you had joint replacement. There are many studies now to show that knee arthroscopy is not a useful treatment for you to undergo. And there is a real trend or movement away from doing knee arthroscopy. The more modern version, where I think where it is these days, is more a pyramid where you start off with the basics. So the basics are diet and exercise. So we know that if you need to shift a little weight, if you shift a little weight, you'll reduce your knee pain. We know that exercise, people that are more active, people that see a physiotherapist have less knee pain. You can add simple analgesics such as paracetamol or occasional anti-inflammatory. We'll talk about the role for injectables, and we'll also talk about joint replacement. Start at the basics, work your way up as you need to. So at a basic level, what causes knee osteoarthritis? Is it simply that we've worn our knees out, that we've run too much? There was a bit of thought behind this, and certainly we do see some athletes who wear their joints out, but far more commonly it is the couch potato. So if you are carrying a little bit of extra weight, if you've got diabetes, if you've got high blood sugars, if your body has got this generalized level of inflammation, that can actually cause knee arthritis. Another good question is, if you've got knee arthritis or if you've got knee pain, are patients happy after they've had knee replacement? On the left, we've got a relatively normal knee. On the right, we've got a severely worn knee with bone-on-bone arthritis. We know that the more severe your arthritis is, the more likely you're to like your knee replacement, because everything in life is relative. So if you've got quite a normal knee, obviously having a knee replacement is not a good idea, whereas if you've got a severely worn knee, then having a knee replacement may give you significant benefit. We know that there's some risk factors for people being happy or unhappy after their knee replacement. So if you've got mild radiographic disease or early arthritis, if you're young, if you're very sporty, or if you can still like run an hour, if you've got pain in multiple joints, if you've got multiple drug allergies, all of these things can be risk factors for you not liking your knee replacement. This number was bandied around a lot, that 20% of people don't improve after knee replacement. The Australian Joint Registry is our national body which tracks all knee replacements and hip replacements that are done in Australia. We know that 80% of patients after knee replacement are really happy, and a further 13% are happy, meaning that 93% in general have significantly improved. That means about 7% are slightly unhappy or do not like their knee replacement as much as we or they would hope. Of that 7% that are not quite so happy, around 4 or 5% are mildly unhappy, in that they are still better, but not as good as they would have hoped. And 2 or 3% are stiff or sore, are unhappy with the results of their surgery. Being worried before knee replacement is also a very normal phenomena. So these results are out of Sydney. We know that 60 to 70% of patients have at least mild anxiety before surgery, and this drops down to 10% after surgery. We're going to examine a little bit about all the non-surgical things that you can do which can help your knee pain or may help you avoid surgery. So first, we'll look at weight loss. So the magic number that people used to say was lose 5%, it will help your knees. There are some studies in this group, Healthy Weight for Life, have published their results, and they've shown that every 2 or 3 kilograms that you lose reduces your knee pain and improves your function. But if you only lose 2 or 3 kilos, you get a little bit of benefit. If you lose 5, you get more. If you lose 10 to 15, you get even more. So if you think you can lose weight, it definitely can help your knee. If your weight is at a good level, that's great. Just maintain it where it is. There are multiple ways to lose weight. I recommend you see your GP or your dietitian, but certainly things like the CSIRO low carb diet series can be helpful. But again, see your GP or your dietitian for some formal weight loss advice. Physiotherapy or exercise, how does that work for knee pain? So I strongly recommend that every patient that has knee arthritis sees a physiotherapist. So if your pain is just mild or moderate, that may be all the treatment that you require. If your pain is severe, then you may still need knee replacement, but it'll be safer and you're more likely to be happy if you've seen a physio first. We've compared the results. So this study is from Scandinavia, where they've compared knee replacement to physiotherapy. Knee replacement gives you better pain relief than physiotherapy, but you can still get around half of the benefit of surgery by just doing physiotherapy. There's obviously no risk with this approach. Prehabilitation, or getting your muscles stronger before surgery, I would again strongly recommend. So when I see my patients at Hollywood Hospital after surgery, day 1, they're usually quite comfortable, the local anesthetic's working. Day 2 is when it gets most sore. They've really got to work through the pain. And the number one thing that they all tell me is that they are happy that they've seen the physios beforehand, because they feel empowered on how to get their knee moving and how to get themselves on the road to recovery. They've shown that prehab improves your outcomes, it improves your quadriceps strength, and it reduces the length of stay in hospital, all of which are desirable. Injections, so cortisone or steroid. So I rarely will use that in a patient that's got knee arthritis and has had a flare of their pain, because it can help you get back to its baseline level. But if you've had years, 3, 4, 5 years of pain, it's not going to help. And there are good studies to show that cortisone doesn't give any long-term benefit, and that physiotherapy is certainly a better first-line treatment to use. There are artificial lubricants, hyaluronic acid, and there's various brand names for that, Synvisc, Monovisc, or Durolane. If you've got mild to moderate arthritis and you've tried physiotherapy and you've still got pain, by all means, these are treatments that you can try. If you've got severe arthritis or need knee replacement, you can still try hyaluronic acid, but it is less likely to give you benefit. Platelet-rich plasma, so taking some of your blood, getting rid of the red cells and injecting the platelets, is a slightly controversial treatment. My reading of the literature is that it may be slightly more effective than hyaluronic acid, or it can be combined with hyaluronic acid. Again, if you've tried physiotherapy and you've got mild to moderate disease, I think it is a reasonable treatment to try. And I would recommend that you consider seeing a sports medicine doctor if that's the treatment that you'd like to try. Stem cells, so taking stem cells from your tummy fat or from your bone marrow, I would strongly recommend against, because there's no evidence that this will work. Cartilage grafting, so taking some cells from the knee, growing them in a lab and sticking them back in the joint. We did try that around 20 years ago, and it does not work for knee osteoarthritis. Knee preservation. So surgery that doesn't involve knee replacement. So clean-up surgery, arthroscopy, although it sounds like a good option because it's minimally invasive, does not give patients any benefit. Everyone feels slightly better after knee arthroscopy. That is pure placebo or pretend benefit. Cartilage grafting like MACI or microfracture, again, do not help. That would be like me giving you some grass seeds and asking you to grow it on bitumen or concrete. The soil underneath is not fertile, so the cells will not stick to your knee. Osteotomy or realignment certainly can be a good option in patients that have got isolated medial or lateral compartment osteoarthritis and are young and doing physically active jobs. So there are many, many studies now showing that knee arthroscopy is no better than pretend or placebo surgery. The first one was done in the New England Journal of Medicine over 20 years ago, and it's been repeated many times since then. The results are always the same in that there's no benefit of placebo or knee arthroscopy. All patients get some benefit, but it is a small and non-significant benefit. So surgery that doesn't involve knee replacement that can help knee arthritis pain. So again, we've talked about cartilage grafting. So microfractures poking holes in the bone, that does not work for knee arthritis. And neither does Macy grafting, where you're taking cells and growing them in the lab. Osteotomy, so splitting the bone and realigning it so you're not weight bearing on the affected part of the knee, actually is a good option for young patients with isolated medial or lateral compartment disease. In my practice, it tends to be 40 to 50-year-olds that are in manual work, and it can buy them 10 to 15 years before they require knee replacement surgery. Looking at knee replacement. So if you've tried the basics and if you've still got pain, or if your knee hasn't responded to the basics, then certainly knee replacement can significantly improve your function and reduce your pain. It's either total knee replacement, where we replace the entire knee, or it's partial knee replacement, where we only replace usually the inside part of the knee. So there's pros and cons of both. So in general, partial knee replacements patients like. The function is slightly better. There are more patients that would consider their knees to be excellent. There are less unhappy patients, and there's a shorter hospital stay. In my practice, I use the Meyerkort robot for doing partial knee replacement, as it reduces the rate of outliers with malalignment of the prosthesis. The Australian Joint Replacement Registry has shown that there's a lower rate of revision with robotic assistance in partial knee replacement surgery. There is a lower risk of major medical complications such as heart attack, stroke, blood clots, and death. The downside is that there's a higher rate of redo or revision surgery compared to total knee replacement surgery. And in general, the rate is 2 to 3 times higher than total knee replacement. So you're trading a knee that feels a little bit more natural, recovery a little bit quicker, and lower medical risks for one that it has a high risk of needing further surgery in the future. Both options can be good. If you're going to consider partial knee replacement, your knee certainly needs to be suitable. And you need to understand that the rate of revision or redo surgery is higher than with full knee replacement. Looking at robotic total knee replacement, so I do all of my total knee replacements privately, routinely with the robot. If you look at all comers, so this is not just robotic knee replacement. If you look at all comers, the failure rate is around 0.5% per year, meaning that if you've had your knee in place for 20 years, there's a 90% chance that it will still be functioning well. If you're a younger patient, the failure rate is higher. If you're an older patient, the failure rate is lower. The causes of knee replacement failure. So early tends to be infection, which is rare, but obviously a big problem. Late failures tend to be loosening, wear, or instability. Being happy after your knee replacement is certainly multifactorial, and it is a lot more extensive than just using the robot to do the knee replacement. So the robot can give us a little bit of extra assistance and enable us to measure what we're doing more accurately, similar to some of the safety mechanisms in a modern car. But for you to be satisfied, I think the important things are that you do your prehab, see your physio beforehand, that you're realistic about your expectations. So most patients after knee replacement are good, but you're not going to be functioning like you were as a 20-year-old. So if you want to walk, hike, travel, run after your grandchildren, in general, you'll be happy. If you want to run ultra marathons or do high-level sport, those things can be more difficult to do. And I think you need to be realistic about what we're trying to achieve after surgery. Not having strong opiate or morphine-style painkillers before surgery is important, as that's been shown to result in worse outcomes after surgery. And time your surgery right. So you do not need to rush into knee replacement. There's no right age. I've had patients all the way from their 40s to their 90s have knee replacement. But I get many patients come in at 60 or 65 and say, look, doc, I need to have it done now. I'm worried I won't be able to have it done in 10 years. So I think you should have it done when it is giving you significant pain or discomfort and affecting your quality of life. I don't think you should have it done because you're worried that your knee may get worse in the future. If it gets worse, we'll deal with it at that point. So I think this is a good analogy for patients. When is the right time? It's when your world is shrinking, when your life is becoming more difficult, when you're starting to avoid things. You're avoiding a walk, you're avoiding going in the shops, you're leaning on your trolley, you're avoiding looking after your grandchildren. Now, I don't mind if you want to avoid looking after your grandchildren for other reasons, but if it is your knee that is slowing down what you're doing, then that is often the time that patients are considering having a knee replacement. Be realistic. So if you're driving a 1970s Datsun and I give you a 2010 Camry, you're going to be happy. But if you come in with a 2010 Camry and I give you a 2011 Camry, you might say, I'm not so sure if this was all that useful. So be realistic, because all surgery has risk and benefit, and we want to make sure that your benefit is planned to be high and that we anticipate your risks to be low. What to expect after surgery in hospital. So get fit beforehand. See a physiotherapist for prehab. The pain team will see you daily and they want to keep your pain at a low to moderate level. We used to make patients pain-free, but then they couldn't get out of bed, they couldn't mobilize, and that led to worse outcomes. So we're aiming to get your pain level to a manageable level so you can start to walk, get your muscles firing, and we can get you home. 2 to 3 nights in hospital is about normal. 6 weeks to be fair, 3 months to be good, and 12 months to get to your best, I think also is a realistic expectation. If you want more information, if you go to my website, which is at perthkneereplacement.com.au, we've got extensive information on non-surgical treatment, surgical options, the basics of starting a physiotherapy program, and even some simple tips on diet, weight loss, and how you can involve your GP to aid you with that. Thanks for listening in. If you've got further questions or queries, I strongly recommend that you catch up with your healthcare professional, such as a physiotherapist, GP, or orthopaedic surgeon.